1.3. I have no idea. I think that's because of curling. I have done it. This is the most insane thing you can ever do. You stand there with a broom, and that loses a lot of weight. And then you have Italy down here with only 8%, which reminds me of this tragedy that happened. You may have read it. The famous sculpture David was recently toured the United States. That's how the Italians gave it to us, and that's how we This is a true story. I don't know how this happened. Well, the take-home message is to people who really study health production, a lot of the research shows, actually in terms of producing better health, there are other things that in healthcare we should focus on. So then how do you justify better health insurance than we have in this country? And I would do it by focusing on the financial protection. There is something to me, ex-German, still a Canadian, and now American, something grotesque that a family stricken by cancer should lose their house and yank a kid out of college. That would be completely unacceptable in Canada, that sort of thing, or in most other countries. Also the ease of access when healthcare need is perceived, and the dignity surrounding the receipt. My wife and I interviewed the German Minister of Health, and my wife asked her, you had only 200,000 uninsured, and yet you're so proud you now have universal coverage. And she said, and you know, why? With only 200, why couldn't you just have not focused on that? And the minister said, this has to do with dignity. I do not, as a Minister of Health, want to think that there's any German who has access to healthcare with dignity. And I was really shocked. She mentioned dignity at least 4 times in the interview, how important that is, this dimension, that you're not a healthcare beggar. So my ideal for a governance structure would be that President Obama would have a Secretary of Health, and under that secretary there would be Assistant Secretary of Health Care, which is what this guy now more or less, or she is. Then you would have an Assistant Secretary of Health Education and Management who focused solely on how to get people to manage their own health better. And then you're the public health, clean water, sanitation. And that would be the more ideal structure that I think in the going forward we really should persuade governments to adopt. The other thing that I should mention briefly is there is a difference between real resource and financial flows. There are people who own time and resources, pills, manufacturing capacities, who surrender real resources to patients. You know, the hospital days, the pills we eat, the doctor's time. And in gratitude, the rest of society gives them claims on the GDP. And that's money, of course. Money is a generalized claim on GDP. And this is what patients get, and that's what the providers get. Now we measure only the upper loop, usually, percent of GDP going to healthcare. But it tells you very little about what patients actually get. And there's a fair amount of research that actually Americans get less healthcare than Europeans in terms of real resources. We just pay more per unit of real resource. This is what we spent, $7,290 in 2007. The last year OECD data are available. Canada spent only 53% of that. But it is, they don't get half the health care up there. They get a lot more care than that. And some of us wrote a paper, it's the price is stupid, why the United States is so different, higher health spending, but lower use of, we have fewer hospital days, fewer doctor visits, eat fewer pills, a lot less of a lot of things than others. The only thing we're good at is high-tech, like MRI machines, coronary bypasses, that thing we consume more of. But here you have differences in prices, cost of hip replacement. In the US, $13,000 is the average. In Canada, only 6, so it's only half as expensive up there. But the procedure is pretty much the same. Cost of normal delivery is pretty standard stuff. Up USA, 7,600, that's doctor and hospital. And Canada is, I don't have Canada on here, will be half. Germany be half, and so on. So the takeaway message, you cannot, just because a nation spends twice as much, go around the world and say we have the best health system in the world. What you can say is we have the most expensive one in the world. You may just give the providers of healthcare a higher quality of life through higher prices. And that's something that should be remembered too. Now when you come to social values, first of all, let's look at Canada. Does Canada have national health insurance? And the answer is yes and no. Because when you look at Canada, this is a picture of Canada. It has 10 provinces, Nova Scotia, Prince Edward Islands, this little one here. If we ever decided to bomb Canada, we'd probably miss it. New Brunswick, then Quebec, Newfoundland, I forgot. Ontario, Manitoba, Saskatchewan, Alberta, British Columbia, the 10 provinces. And then we have 3 territories. The provinces are sovereign governments like our states, but the territories are administered by the central government. The people who live there are the Inuit. They have their own language. What is it, Inuktitut or something like that? And in fact, I found the national anthem of Canada in their language, written and so on. And it is a legitimate official language of Canada, although I think less than 100,000 people live there. Not that many live there. It's just amazing how big Canada is. Now this area below, Canadians know as the territory of silver medalists. Had to get that in. And of course, they view us as unarmed North Americans with health insurance. Ian Morrison's description, he's from the Institute of the Future of Canadians, and I think that makes a lot of sense to me. Now, so every province in Canada actually has its own government-run health insurance system, but it is bound together to common standards through a system of cost sharing, which initially, when it started out in the early 1970s, the federal government paid half of what a province spent on health care on the condition that the province would dance to the tune made by the federal government. And they had very strict ethical guidelines of what the system should look like. The way they do health reform in Canada very often starts as follows. They will, first of all, literally write down in written language the ethical goals that the health system should obey. They actually articulate that. They start at that point. And from it, they develop what that health system should be like. For example, the reason why Canadian health insurance is government-run derives from the ethical principles that they impose. They say, if you want to obey these principles, the best instrument to do that is a government-run program and not private insurance. So what they did is in the 1961, the government appointed a Royal Commission on Health Services, presided over by Supreme Court Justice Emmett Hall. It's known as the Hall Commission. And they crisscrossed the country, visited, studied health system in other countries, interviewed people from the healthcare delivery system, and had 26 research papers. Our late colleague Charlie Barry was very active in working for that commission. When they came out, they recommended health insurance in Canada should be universal and portable, not tied to the job. It should be comprehensive, although they didn't cover drugs, I must say, at that time, or long-term care, which no one really ever did. It should not permit extra billing by the providers, and there should be no user fees at point of service, no cost sharing, no co-insurance, no deductibles. The individual's contribution to healthcare should be based on ability to pay and nothing else, not health status. In a nutshell, Canadians, in the ideal, should have the same healthcare experience when they have an illness, by which I mean access to care, the process of care, and whether you go broke, your financial impact of that on your budget. That is the ideal. Is it 100% achieved? Usually probably not. In the UK too, I just was reminded by somebody that in the poorest area, people will get 12% less likelihood of getting surgery for a certain condition. You know, it's the ideal that matters. Now, if you download Canada's healthcare system, it's a nice publication, about 20 pages, and they said, modifications and major reform have been made to Canada's system ever since. As has been recognized in every major review, the basic values of fairness and equity that are demonstrated by the willingness of Canadians to share resources is always reaffirmed. And to see that, there was a report by Roy Romano, who was governor of the province of Saskatchewan. He was actually a classmate of mine when I went there. And he had a commission in the year 2001, I think. And look at the French title, Guided by Our Values. That's the title of the reform. And the English version is Building on Our Values, but values is really up front. And right up front in the page XX, he writes, Canadians remain attached to the value. In their discussions with me, Canadians have been clear that they still strongly support the core values on which our system is built, equity, fairness, and solidarity. These values are tied to their understanding of citizenship. So the health system is viewed as a cement that makes a country, a nation, out of a group of people sharing a geography. It's absolutely part of that. And when you're a Canadian, which in many ways I still am on those values, and many other things, I'm American, but on the value system, I'm very Canadian. We just believe that this is part of citizenship, that you should have that. And then he says, therefore, it has to be a national program that all Canadians share. It could be locally administered, but they have to be national, you know, rules and guidelines. And it's not here where, for example, the threshold for Medicaid in Mississippi is so much lower than it is in New Jersey, so we do not treat two Americans the same way at all. And the Canadians try to do that. Now, here you have to appreciate Canadians really believe to achieve that objective, you need a government-run system. One could get by with having it like the Dutch, who try to have a national system with private insurance, but you need a lot of regulation. And it's in some way that turns out to be a private insurance in drag, because you're really just getting a lot of regulation. The Swiss and the Germans have that too. The Canadians simply, maybe I'm wrong, but when I lived there, we were not scared of government because we thought we elected it. It was of us. So, you know, people don't run around, I'm scared of government. You know, I bought this T-shirt at Union Station. I don't think Canadians wear T-shirts like that, right? I love my country, but I'm scared of government. And this idea that somehow government is imposed on the American people by somebody and is the enemy of us, that would be alien to Canadians. They don't think this way. You go here, I Googled, and sure enough, here are these T-shirts. You can buy plenty of them. I love my country. Here's another one. I love my country. So this is a big fad, apparently. And there's a lovely book, First Do No Harm, Making Sense of Canadian Health Reform. And I quote from that book where they say, while the US value system respects above all the freedom not to be interfered with by government, we Canadians balance the freedom of non-interference with the freedom to choose governments that will act in ways that legitimately constrain individual choice for the public good. In other words, Canadians feel part of our freedom is to elect a government that restricts our freedom. Healthcare is one such area where literally, in order to save each other's lives, we have constrained, but not prohibited, Canadians' freedom to buy their way to the front line. That just isn't done. And so you could say, we, the people of Canada, chose a government that robbed us of the freedom to jump ahead of the queue with money. Unless you go to the US with your money, where you can do that. And then they say a free choice to buy something you can't afford is no freedom at all. Now here you have the consumer-directed healthcare movement, where the idea is to have very high deductibles, up to $10,000 for a family, but they're marketed saying you will be in control of your own healthcare. You see, a Canadian would say, yeah, but what kind of freedom is that if you don't have the money to exercise that control? So that is a very distinct view. Now, do Canadians loathe their system? If you do surveys, the Commonwealth Fund every year does a survey of something like 10 countries now, and it's always the same questionnaire. Lou Harris does the survey, and it's been well honed. But here was the latest survey that I could find, 2007, when you ask Canadians and Americans, the system works well, only minor changes are needed. 16% of Americans will say that, but 26% of Canadians say it works actually pretty good. System needs completely rebuilt. A third of Americans say that. They're very dissatisfied with the system, and only 12% of Canadians. So they're not unhappy with that constraint they imposed on themselves. Even though it is a fact, we have infinitely more MRI units here and CT scanners, and you do queue up for MRIs in Canada. I wish they wouldn't. I wish they'd spend a little more money to maybe have some government-run MRI machines, because I'm sure if they did, you could do this for $200 a pop. I'm almost sure a well-run MRI center should be able to make money at $200 a pop. Here, you call a radiology group 2,000 in this town. If you ask, do you have access problem? Out-of-pocket spending more than $1,000, 30% of Americans, 12% of Canadians, and that will be mainly for younger people who have no drug coverage or long-term care outlays, had serious problem paying for medical bills. US 19, Canada 4, did not fill a prescription, 23 in the US, 8% in Canada, skipped medical tests, did not visit doctor. See, that creates this dissatisfaction that Americans have with an otherwise great system. At its best, our system is unrivaled in the US, but on average, it has these access problems. The interesting thing is even physicians in Canada are more satisfied with their system than American physicians are with theirs, which is somewhat amazing. System needs to be completely rebuilt. For some reason, I reversed the axis here. 15% of American physicians say that, only 4% of Canadians. Fundamental changes are needed. That's both equal, but only minor changes are needed. 1/3 of Canadian physicians will say that, but only 17% of Americans in this. And if you ask physicians, what are you so dissatisfied with? The overall experience with medical practice, the hassle of dealing with 20, 30 private insurance groups, and then with a government that criminalizes healthcare as Medicare does. Every doctor, every hospital executive is viewed as a latent criminal by government in this country, which is a terrible approach. Canadians don't do that. They're managed by exception. Doctors and hospitals get paid, and they only look at the outliers to see whether there was fraud. But everyone else, they just get paid, period. No one questions anything there. Income from medical practice. Canadian doctors make less, although they have lower practice expense because they have no billing clerks. They don't need any. They have a lot less staff. And freedom to make clinical decisions. Canadians say they have more freedom than Americans. Why? Because they're not in HMOs with networks. They don't have those up there. Which is an irony that you always say Canada is government run, you don't have freedom of choice. You do, complete freedom of choice of doctor and hospital. Here, if you're in an HMO, you do not. So you then hear that many Canadians come to the US. Some do, no doubt. The Premier of Newfoundland came here to get some procedure, heart, coronary bypass or some damn thing. So yeah, you had it, and Bourassa of Quebec came here once. You do have that. And then the snowbirds who go to Florida when they get sick consume healthcare there. But this has been exaggerated. There's an interesting paper, Health Affairs 2002. They actually seriously looked at the insurance files and other data sources and found surprisingly few Canadians travel to the US despite the persistence of the myth. So yes, it's there, this traffic, but it's not as big as people think. Now let me turn to the US. First of all, if we have the best health system in the world, as we so often claim, why the call for health reform, if you actually think about this? Well, the first reason is the rate at which healthcare has grown is unsustainable. Here you have per capita health spending and purchasing power parity. I trembled saying this in front of Professor Deaton, who gave a wonderful presidential address warning us how difficult. But Angus, between Canada and the US, you would accept it. Well, was it between Cameroon and Japan? You would not. Okay, I got that right. But you see, Canadians spend considerably less and have been since the 1970s when health reform, when Canadian Medicare actually came into being. And here is as a percent of GDP, and again, we're considering Canada is now slightly above 10.1%, I think it is, and we're at 16, cruising on 20 in this country. And here is a graph in a report, November 07, Congressional Budget Office by Peter Orszag, then Director of Congressional Budget Office, now the Director of OMB for President Obama. And he had predicted 38% of GDP will go to healthcare in 2050. That's an underestimate because from 2040 on, he assumes health spending grows only at the rate of GDP. He has this little kink in here, which is artificial. We don't know if that'll happen. It may happen. Interestingly, down here you will see that Medicare and Medicaid are part of the culprits, but everyone says the reason American health spending is out of control is this government-run programs. That is not in the data. The data show that everyone, whether private or public, marches roughly to the same tune. But do we as a people want to blow 40% of GDP on healthcare in the year 2040? That is the question. If we could get rid of Alzheimer's, cancer, and have a Viagra pill with a 50-year use life, maybe. But I'm not sure that we actually want to do that at this time. Professor Trusser, you think we'll have such a the other problem we have is we are pricing the middle class out of healthcare. There is a website, Milliman, they are a benefit consulting firm, and they have a medical index where they add for a database of 10 million American privately insured at the place of work. So that is under 65. And they then compose out of that, adding up the family's out-of-pocket spending, the family's contribution to the insurance premium at work, and the employer's contribution. So what you get here is roughly what it costs per family under 65 in America now, on average, healthy and sick average out. Well, that's $16,700, probably $18,000 this year for a family of 4. That's a huge amount of money. And then how is this financed? Well, it comes at the place of work. But we economists are convinced, both by theory and empirical research, that the bulk of the employer-provided insurance, even if the company pays, quote, the premium, ultimately is taken out of your take-home pay. You know, we have papers to show that. I give lectures on it. It would drive you nuts because they're all full of math. But it's quite convincing a story. And there's empirical research. So the wage base is the donkey that carries this load, no matter who writes that check to the insurance company. That's the message. Now, here you have the income distribution. Oh, this is 2005. 2007, I have, this is, I don't know how that slide got in here, but it didn't change much, because income does not change much over time. No, certainly not in 2 years, the last that actually was available. But you see roughly one huge group of people making more than 20 and less than 55,000 almost comprise 1/3 of the American families. And for those families, a burden of $16,000 now, or $18,000, is huge. And it has to come out of basically the wage base that they earn at the place of work. You go to Macy's, Home Depot, they make $25,000. That's basically what they make. Their wage base may be $60,000 together, if you have husband and wife, one at Walmart, one there. That's what they bring home. Now the green down here, these are the people who do get Medicaid, housing allowances, earned income tax credit. We do funnel federal money there, but we do nothing for the blues, the cab drivers, the limo drivers, gas station attendants, restaurant workers. You go to eat at Shanghai Park, those people don't have insurance. And then the yellow up here is Princeton, New Jersey. Now, I took here a couple with a wage base of 50,000 and say, let that wage base grow at 3%, which has been the average in the last 10 years. And right now it's less than 2%, but let's make it 3. And let health spending grow at 8%. And what I showed you was actually 8.7% compound. Let it be only 8. That means 10 years from now, over half of the wage base of that family would go for health care alone. It'll be then something like $86,000. If you were optimistic and say the wage rate grows at 5, this won't happen, and health spending only by 4, which might happen, you still go 1/3 of the wage base. So what my point is, the lower half of the income distribution, the blues, are sailing into a perfect storm in healthcare that has not yet hit. They have no idea what will happen to them if health reform fails. And maybe it should, and maybe they will get a teaching moment they'll never forget. And maybe they won't run to town hall meetings and talk about government takeover. Maybe they will go on their knees and beg for government to come into their lives. We shall see. There's also insufficient value of the dollar. I have a whole slew of slides. I'll show you only one from the Business Roundtable, who are to the right of the political center. And they commissioned a study where there were some 12 health economists, and they took the following approach. Relative to what Europeans spend and what they get for their money, what do we get? And they discover we get 23% less value than we should, given how much we spend. So it's a benefit-cost problem that we have. So that then leads you to the agenda that basically both the Democrats and the Republicans have the same agenda in terms of the goals they want to achieve or claim to want to achieve. Insurance reform means we now have close to 50 million Americans without any health insurance, and another 25 to 30 who have shallow insurance. Shallow is treacherous. It's not only when you have deductibles up front. Even worse is when you have limits on top. You have a limit drugs, and then you need a specialty drug that costs $6, then what, right? Or you have a limit for hospitals of 5,000 or only 20 days or something like that. These limits hit you, and when you're really sick, you realize you're actually uninsured. And so that's what we're talking about. We want to get rid of that. We want to have reform, not the market for employers. That one won't even be touched by this reform. I always hear, what is it, Candy Crowley on CNN? She says Obama is rearranging 16% of the economy. I want to write to her and say, I want you to tell me what Obama, if that bill passed, what would happen with your health insurance from CNN? And the answer is nothing. She wouldn't even know. Nothing. Obama is not touching much at all. As a matter of fact, he has $1 trillion in subsidies over 10 years for the poor. Total health spending over that period is now projected to be at $34 trillion. 1 trillion is 3% of 34 trillion. So that's all he's talking about. This is not a budget buster at all. So for Candy Crowley to say Obama is rearranging 16% of the economy is a flat lie. Now, I don't think she's lying, she's just ignorant. But ignorance is excusable. Now, healthcare delivery, we want healthcare to be clinically integrated the way the Kaiser Permanente has it, seamless from ambulatory care to inpatient care to convalescent care, hospice care, if that's the route, but seamless in some way. When you do international surveys, our surgery, our stuff is great in the US. However, the handoff from hospitals back to the ambulatory care sector is among the worst in the world. Those of you who had operation had very mixed experiences. Some docs are very good and some are not good at all. So we want that. We want greater transparency. My wife and I made this experiment. We called the Princeton Medical Center and say, let's pretend, you pretend you have, you're uninsured, a little bit of an accent, good. Say you're making 70,000, and that means you're not qualified for poverty discounts, etc. You want to know what a normal delivery costs. You're on the board of that. I couldn't get it. She couldn't get it out of them. Could not get it. So I got mad. I phoned up and said, I want same thing, description, you know, little accent, help. And I want to know the price of a colonoscopy. Could not get it. I told the lady, this is your lucky day. I'm chairing a commission on a hospital in New Jersey. And guess what you just told me? It'll be in the report. I will report. But this governor we had no temerity, so there are no prices. You try and get prices here. So we want that, and Republicans, Democrats all want this. We want to shift away from fee-for-service, piece rate, which leads to over-servicing and fragmenting of care, to bundle payments for episodes of illness, where there's a big payment, somebody gets it, and that's it for the whole case. Say a hip replacement, one fee. Everyone has to be paid out of that. And we want to discuss whether we want to blow 40% of GDP. That's the agenda. That's all there is. Why President Obama has never been able to produce a slide like this is beyond me. No one in the White House knows how to make slides. You need to do this. You need to have a public-private sector partnership to do health information technology. Health information technology is the most backward industry. Look at banking. You flew to Budapest. I needed Florence. I go to some street thing, stick in my card, and I get Florence. You know, here, you go to the hospital, each time you have to fill in these 20 pages where they ask you everything. You go to another department and have to fill it in again, instead of having that on some computer. We want a vastly increased budget for comparative clinical effective, what works and what doesn't, and cost effective, meaning what is actually the cost of an extra quality adjusted life year if you use this drug. Say Erbitux. that buys maybe 2 or 3 months more life when you're terminally ill at a price of something like $250,000 per quality adjusted life year. And the question is, do we want to spend this or not? Seems a legitimate question to raise. And we need a farmer's market for individually purchased insurance, like a farmer's market for potatoes and eggs, here where all the insurance are exhibited. Princeton has a farmer's market for insurance. The benefit department gives it to us, beautiful website, and all these things that hang out on the 4th floor, the descriptions of these policies. That's all an exchange is. It's what every big company has. We would like, I think there should have been malpractice reform. Why the Democrats stuck their thumb in the Republicans' eyes on this is beyond me. As a courtesy, they should have at least addressed it. They didn't. It's arrogant not to. I favor an independent commission to help set prices for Medicare and certain rules as Germans have. That's the package, okay? So that was supposed to be done. Why is that, incidentally, going back? The only thing that can actually be done this year is the thing in blue. That's the only thing that could be legislated really this year. This integration, you can't really legislate that. Tomorrow, by July 1st, you ought to be integrated. This will take 10 years to do because you're dealing with eagles who are to fly information known as MDs. That'll take a long time to get done. This will take a long time, and you know why? Technically, to figure out what is the best practice for an illness. You know, what all should be delivered in a coronary bypass? What's the best clinical practice? How much should be paid for that? But that's technical. We can solve this. The real issue is, to whom do you pay this bundle? If you pay it to the hospital, doctors become subcontractors to the hospital. Do they want this? You pay it to the doctors. Who? The surgeons? The primary care guy? Can you imagine a surgeon holding out his hand to a primary care physician for a token? I mean, this is politically huge to do. And then this other debate will take time too, because you know Alfred E. Newman's famous equation. Every dollar health spending is someone's healthcare income. And those guys have been surgeons far more powerful than the Iraqi version. The Iraqis carry RPGs. You can deal with that. These guys carry little bags of money with which they buy the affection of legislators. And you cannot defeat that, and as we have seen. So this will take more than a decade to do. So when Obama said, I'll be the last president to discuss health policy, he must have either been ignorant or lying, one of the two. That is not true, and he should have known better. This will be an ongoing process. I don't know why he said that. No, orator, maybe. Now, why is U.S. health reform in trouble? And here we go back to the social ethics. In the U.S., we have two powerful, somewhat extreme views. The U.S. liberals really look to Canada and say, we'd like to have that too. There's a single payer movement and so on. U.S. conservatives really believe healthcare should be your fiscal responsibility and I shouldn't have to pay for you. And those are not small, they're not extrema. It's about one-third. And then you have this third, people like me in the middle, centrists, and the center, the political center, and skating on thin ice here is political sciences, but this center has not taken both and said, can we fashion something out of this? And maybe the president, well, actually he tried, in fact, to move there, but for some reason, either he didn't ask the Republicans enough or they decided never to come to the table, whatever it was. This time around, we did not get a center bill that both sides could sign onto or would sign onto. So that's where we now are. I get a lot of emails from my blogs. I blog in the New York Times. Here's this guy, Nicholas Fay, Do we have the money to be our brothers and sisters' keeper? The answer is no. Why would I as an individual want to pay for someone else, someone who's unwilling to get a job and pay for what they need? Why should we cut what doctors earn because someone is unwilling to pay them what they deserve? Why? The image that every uninsured is just a slob who doesn't want to work is dominant on the political right. They simply believe that. And it's hard to overcome. And President Obama, with all of his skills of talking to people, has not been able to get through. So what we do is, since we can't agree on ethics, we just make policy, we set economic parameters and see where the ethics will lead us. And if it doesn't stink to heaven, we'll be happy with it. And usually we're quite tolerant to the stench that sometimes we create. There's a website I could give you, if you ask me, University of Missouri School of Journalism, where they had a series of articles in the Wall Street Journal of what happens to people who cannot pay their hospital bills. Did you know sometimes they get jailed in this country? Literally jailed. There's a quote of a woman, she says, I went to the station to be arrested. I didn't want my kids to see me arrested. She had a miscarriage, worked in a pizza parlor as a waitress or somebody working there, and couldn't pay the bill for the miscarriage. And it was tragic, this sort of stuff. I think the president could have done a lot better at the summit, and I actually did smuggle that into the White House and say, why don't you do this? You have this table here and say, opening up on the ethics the way Canadians and everyone else does have. Let's get the ethics on the table here. And what would you have done? You could say, now, here's a family with $20,000 to $30,000 income. What amount of money out of that income should we ask them to pay for their health care before we help them? That is a number, a dollar number. If you had done that on TV, people can relate to that. And then he could have put his number here and then asked the Republicans, come up, here's a grease pen, here's the easel, write your number down. What would that number be? Have you any sense of this? That would have been very powerful to open up this summit. I don't know why they didn't. In his 11-page thing on the White House, he has these tables, actually, but he has percent of income. Half the people wouldn't know how to calculate 18%. You know, with 7.5% of 28,000, you're losing most viewers. Why not dollars? So I'm puzzled by him that he wouldn't have, either if he cannot teach, then he should have gotten a high school teacher who could do it. Or a marketeer. Anyone who's a great marketing expert at the Wharton School could do that. So that the other problem is the American people actually really don't know what they want in healthcare. I think other nations have a clear head on that. Americans, when you ask and you read what they write, they want a system where only their doctor and they determine how to respond to a medical condition. They want a system that never rations healthcare because that's un-American. They want a system that limits the family's out-of-box spending to healthcare. That's what they're screaming about. They want to keep low premiums and low taxes. Does not allow insurers or government ever to use cost in deciding whether or not to cover a procedure. So no matter how much the procedure costs, it must be covered. This was actually in the bill, in the stimulus bill, $1 billion to do this kind of research. They called it cost effectiveness, and Senator Lautenberg and Specter went and crossed out cost and made it Clinton, because it is illegal to use cost in this country. Every country, nice in England, uses it. Americans want a system that doesn't mandate individuals to purchase health insurance if they don't want to. On the other hand, they want a system that grants every American the moral right to get critically needed care, even if they're uninsured and can't pay for it. That is cognitive dissonance, right? I mean, think about holding both views. It controls they want a system that controls Medicare spending, which is out of control, as long as it doesn't reduce payments to doctors, hospitals, or anyone else. How do you do that? Provides universal coverage as long as it doesn't raise taxes and cut spending, that's all. And this is very difficult. And the town hall meetings are full of people like that. Here is the classic, rugged, uninsured American individualist. Look at his posture. He's about to take a spill. His headgear is probably a bandana, and his body, if you go to Colorado, you see them, you know, I envy them, the freedom, t-shirt flapping, bandana, Harley, you know. But if they take a spill, then what? They expect to be helicoptered to Denver. They expect to get absolutely everything that American medical science knows, and if they can't pay, that's okay with them. And this is really cognitive dissonance. You want to really monitor it, read the Wall Street Journal editorial page. They will tell you they abhor raising taxes and increasing government spending. The page constantly says Medicare spending is out of control. But every time when the government wants to control the payment of doctors and hospitals, they scream that you're underpaying these guys and shift healthcare costs to the private sector. And they abhor the idea of using cost effectiveness to make coverage decisions. That's the Wall Street Journal. They're educated people, and they suffer from this, in some sense, mental illness, you could say. And our system of governance, I'm not a political scientist, but there must be some difference in the way parliamentary systems and our system make policy. You cannot purchase the affection of members of parliament in Canada retail. You can't do it. You'd have to buy the whole party, wholesale. But in fact, it's illegal, isn't it? I think it's illegal to lobby like that. Here you can buy piece by piece. So it's extremely difficult to make policy. And then, you know, our public discourse has reached levels. Here was an editorial on cost effectiveness analysis. And they bring in Adolf Hitler in this thing. Here is Newt Gingrich waxing mushy on the virtue of living wills. He talked about Gunderson Hospital, where 90% of the patients have living wills, and they're much cheaper than everyone else. And they said if everyone of the elderly had a living will in America, we could save $33 billion a year on Medicare. That's what he said, editorial. Half a year later, that's one thing about, I have to say, the Democrats, they have a certain degree of naivete that's almost touching. They put that in the bill. Now, I wouldn't have, because you already know this is going to be trouble. But they put it in Section 1132 in that bill. And all they put in is that the physician would be paid for that by Medicare. To do that, they pay him every 5 years, no more frequently. But they say, if you counsel a patient on living wills, we will pay you for it as a medical service. It's all that bill says. And what came out of it? Death penalties. It was Betsy McCoy, former lieutenant governor, Sarah Palin, Senator Grassley says, well, I can't be for a bill that kills Granny. That's what he said. And Speaker of the House didn't have the sense of honor to set the record straight, as he should have after writing such an editorial. So I think that is unfortunate. Now, what if health reform fails? Who are the losers? The losers are the middle and lower income class Americans who will stagger under the fiscal burden of health care in the absence of these subsidies. They will really bleed fiscally to death. The health insurance industry will suffer a lot because they would have gotten 30 million additional customers with about 100 billion a year federal subsidies. That's money of which they keep 3 to 5% as profits. This is why I had this discussion today with someone from PBS. You have to wonder why WellPoint and the other companies came out with 30 premium increases, right? You wonder, what were they smoking? In the middle of a health reform, couldn't they held off 1 year and just let this thing? But what if I tell you this was actually very useful to them? What if one had the hypothesis they wanted to scare the American people into passing this bill? Because when everything's said and done, no matter what Obama has unleashed on them verbally, the truth is they will make out like bandits if this reform passes. The hospital industry, no matter what their belly aching is over the $155 billion they were supposed to contribute, my eye, that was only a cut of the future growth, which was something like $7 trillion of federal dollars. They will be a big loser because they get all these uninsured, and yet will be mandated to treat them, and they won't have it. The pharmaceutical industry will be a big loser. Imagine 30 million more customers insured. The winners will be high-income people who would be asked to the cashier's window, not big time, but we would feel it in sundry ways. The Medicare beneficiaries, because there was to be 177 billion over 10 years to be taken away from the Medicare HMOs, because they now get paid 14% more than it costs Medicare to keep an elderly. So if an elderly leaves government-run Medicare and goes to a health plan, the taxpayer has to pay 14% more. President Obama wanted to take that back, but with that extra money, the insurance industry did buy them extra benefits, and the elderly would not get those who are in HMOs. So they would be happier. The device industry, they were supposed to fork over 20 billion over 10 years. They were belly aching, so they're happy. All right of center think tanks, because it's a huge victory for them. They can claim, we defeated it, you know, this thing. Wasn't there, the RNC now came out, I forget what they had some terrible thing to say about Democrats. And the Republican Party, I don't know, you'd have to ask Larry Bartels or Nolan McCarty people who study this. My own sense is it's not clear it's a victory for them, because the Democrats might engage some marketeers and turn that against them and say, they blocked it, you will suffer. We'll see how that goes. But you know, health reform in America is not like Canada, where you have a royal commission that lays out some things, and then a party says, this is our platform, it wins, like the Liberals did in '65 or whatever, and put it in. Here it's messy, and it'll be messy no matter who tries it. So this was last year. Excuse me, can anyone tell me if this is the path to comprehensive reform of healthcare? And the answer is, yeah, that's the path. And so let me end right here.
That was incredibly stimulating. We have time for some questions, after which we're actually going to have a reception in the Schultz dining room next door. So, but why don't we take, say, 10 minutes worth of questions?
Sure.
And you're comfortable doing them?
Yeah, I'll do that. Yeah. Sure. Well, see, business has been talking about health reform as long as I can remember. When President Clinton was president-elect, lived in Little Rock, Arkansas, all the jets flew down there, and the executives pleading, please do something about health reform. But when he did, they stabbed him in the back. The reason business wants to keep doing what it does, it's a tremendous come-on in the labor market. As long as there's no government program, as long as there's no good alternative, people will work for you even if they don't like you just for the health insurance. It's high-powered money. It actually is more than salary. It's worth more than salary to the employees. So business has been very tenacious in holding on to big business to employer-provided insurance. Some businesses choked. GM died over healthcare. I mean, yes, they didn't have very imaginative cars, but they weren't bad. What really did them in was $70 billion of unfunded retiree healthcare liability when their net worth was $21 billion, and a health bill for the workers that was unsustainable. But this one absolutely killed him. The CEO was a friend of mine, Rick Wagner, and he told me, all my cash flow goes into retiree healthcare. I have nothing for R&D. That's what he told me. So GM essentially was owned by the health system and then died over it. So some companies, it's a risky business for them. I don't think business is an ally in the fight for health reform. Small business may be, but not big.
You were talking about the fear of government. You know, when you make the Tea Party guy says, I don't want government interfering with my health care.
Yeah, you hear that.
The point that I find interesting that nobody was making is that when Clinton came out with his health care plan and it was shot down, basically because nobody wanted some damn bureaucrat to be making medical decisions for it. So it was shot down, and the same thing happened, except it was the insurance industry.
Yeah, as a matter of fact, I wrote a paper then called The Utterly Predictable Managed Care Quetch, because I said, okay, you killed the Clinton plan, you will now have managed care. And you will kill it too. And then you will have nothing. At least managed care had a promise that they got you access to a doctor and to a hospital, and they covered most things, but they would restrict you. They would occasionally say no, right? And managed care backlash came, and we killed it. And then we had this mess we now have, right? Which Americans are not happy with either. That's where my cognitive dissonance comes from, and saying, you've never been happy with anything that has been styled for you. Professor Alan Entel from Stanford had a design that goes back to Paul Elwood and our colleagues Red and Ann Summers, who actually were the first to sort of think of this idea of giving people a choice of private health insurance plans like Kaiser. And you know, you pick your own regulator, and if you don't like it, you don't have to emigrate. You just pick another HMO. That was the idea. I still believe that's the best deal Americans can get, short of a government plan. However, you're on Medicare probably. How often does a bureaucrat actually interfere in your health care? I mean, they pay, but do they ever say you cannot go to that house?
I've been on Medicare.
What?
Once in the 15 years.
15 years, yeah. Do they ever say you can't go to this hospital? Aetna will. They say you can go, but we won't pay. But Medicare doesn't do that. Where the idea comes from that bureaucrats sit there and determine what a doctor and you do in the private practice when you're actually on Medicare. I'm not on it, but I wonder, how would that actually work? They don't even have the capacity to do that. Private insurers do have the capacity to call your doctor and say no.
Professor Reinhardt, you showed, I believe, 63% of Canadian physicians wanting or calling for fundamental change in that system. Can you tell us what's on their mind?
Be interesting to see. I always ask that question too. My hunch is they would like to have some more capacity in imaging, some more capacity in heart cardiovascular treatment in general, cardio treatment, and probably somewhat higher reimbursements. That's probably what they would be complaining about. They don't have insurance hassle. You have a little card like American Express, run it through a machine, then the machine knows, oh, Dr. So-and-so is seeing this patient. Machine knows that instantly. And then afterwards, the physician will code in what he or she has done, and in 2 weeks, they get a check. So that can't be it, the insurance hassle. But the payments are low. A pediatric visit, about $30, $40. It's probably too low. And that may be a part of their complaint. But aside from that, it's an interesting thing, though, that should be followed in our surveys. And I'll take that under advisement. You had a question way in the back.
Do you believe that
No,
rationing
it's a lady
care-
in the back.
Sorry.
Want to be fair.
Personal health savings accounts as an alternative to insurance.
Yeah, a personal health savings account or health HSAs or Medicare savings account. The idea is that you should set aside money to pay out-of-pocket expenditures when you have deductibles or co-insurance. And then you say, well, who's stopping you to do it? But the angle here is you can tax deduct what you put in there. And I rebel against that as a notion because in New Jersey, in my income class, I'm in a 60% tax bracket if you add up all the taxes. The federal taxes, social insurance, unemployment insurance, and the 10.7% state or whatever it is. I don't do our taxes, but it's big, I know. So it's probably 60. So if I have a root canal that costs $1,000, that isn't covered, and I pay the $1,000 to the dentist, my after-tax cost is only $400, right? Because I pay it with my account. A gas station attendant saves at most, he might not even pay federal income tax, but he pays Social Security taxes in a little state, maybe 15%, so that they pay $850 for a procedure that cost me $400. I don't see the ethical foundation of that approach to healthcare financing. That's why I'm against the idea. If you were to say, anyone who puts money in a health savings account, the feds will pay 30 cents. You get a refund of 30 cents. Or we chip in 30. You put in 70 cents, we'll put in 30 automatically. I would consider that useful because that would be sort of an inducement to set aside money for healthcare. But that's what you need to do.
Yeah, I was just going to ask, do you feel that rationing care ultimately has to be part of any equation that reduces overall healthcare cost? And personally, I'm a surgeon. I'm the chairman of the Department of Surgery at the hospital down the street you mentioned. And I see people in their 80s with Alzheimer's come into the hospital with a couple PVCs, and before you know it, they have a brand new $50,000 defibrillator. I don't understand it, and unless there's some way of preventing that kind of thing from happening, I don't see it stopping.
See, they might not do that in Canada or in England. And those are civilized countries. They just simply say, given other needs we have, particularly the cognitive development of children, which is so important. If you read Jim Heckman's work on that and your work, you really become impressed. If you really care about America's future, you really want to worry about its human capital. So we have all those needs, and maybe they would say no. And they do it in an organized fashion. But you cannot have that debate here without, my daughter sent me a website, and my wife had written a paper, and they said, oh yes, she is married to this notorious Nazi operative on the web. Our daughter said, Dad, I didn't know that about you. And in fact, it was Congressman Gingrey, a physician from Georgia. I was testifying, and he said, you wrote a blog in the New York Times saying the idea that human life is priceless is romantic and silly. And of course, most economists will tell you that because we don't act as if it were, right? So he was red in the face, and he said, "How dare you tell me what my life is worth?" And I said, "I didn't say that. I don't, whatever. But I have a right as a taxpayer to say how much I would pay for your life. That should be reasonable, because after all," I said, "you did that to my son, whom you sent into combat without a flak jacket. Don't tell me you didn't put a price on his life." And you got doubly red in the face. What really troubled me about that exchange is it was stricken from the record. He took it out. I wish he hadn't. I would have liked to see it stand, because I was very angry, because he said, "Well, that is German thinking of another era." And I said, "No, it isn't. This, you guys sent our troops out there, underarmed, under-armored, and you put a price on their lives. And there's a lot of people in the hospital in Bethesda and Walter Reed without limbs who are there because the Humvee was unarmored." And again, our son casually tells us he didn't have a flak jacket. We almost hit the roof. Because they weren't enough. They said, "Why not?" Budget, So that is, I think, we need a debate on this. I was on NPR just saying it the other day. We need a reasoned debate, but you can't have it in this country. And this is why I get angry at people like Newt Gingrich, who has the stature and he's bright, he's an intellectual. He could engage in that debate from the right in an intelligent way, as Bill Frist, for example, does and would. Our student, Princeton, Woodrow School graduate, he does engage in this debate. Yes, at some point we need to address that as an issue. But so far, I think you saw what happened when you not even talk about it, but saying, let's pay for a methodology to look at cost